Right. All right. So now let's say it's 2 years later. You were able to get your this patient. You put them on medication. They had a couple seizures in the beginning. Now they've been seizure-free for well over a year, and they're considering coming off of medication. So I guess starting with the case where we said primary generalized or juvenile myoclonic epilepsy, would you try coming off, and what are the chances of success, and what are the risk factors for recurrence?
Yeah, these discussions about coming off of anti-epileptic drug can be relatively complicated, and in general, when I have a discussion with patients about coming off drugs, it's a long one and takes into account both epidemiologic factors, the type of epilepsy as you've alluded to, but also the patient's personal situation themselves. Some things that can help guide our decisions are some older trials. MRC stands for the Medical Research Council. This is a slide from the anti-epileptic drug withdrawal study. And so basically this compares patients who, after a period of time, like the patient you described, either continue on anti-epileptic drug or have a slow withdrawal from anti-epileptic drug. And patients that were included in this study were patients where that was at least a reasonable consideration and there was some uncertainty by the clinician about whether to stop or continue. The results, I think, are relatively intuitive, and those are that the likelihood of being seizure-free is obviously going to be higher if you continue anti-epileptic drug than if you stop it. So no withdrawal is associated with a long-term seizure freedom rate of 75% or so. Slow withdrawal is associated with seizure freedom rate of a little over 50%. This does mean that in 50% of people who you start drugs, you might be able to successfully stop them and still have good long-term seizure freedom, but I think that's a bit high, actually. In the patient you described, there's been some new data about juvenile myoclonic epilepsy. And you know, in general, we're very hesitant to stop medication, but there are a few patients where you can, and a recent study looking at the original cohort of patients with juvenile myoclonic epilepsy showed that just under a third of those patients were actually seizure-free over the long term on no medications. So It can happen. Driving can be a major consideration as well when we stop anti-epileptic drugs. My practice is to, because of this data and others, to say that we have to wait a period of time. You can see on this graph that the highest rate of seizure recurrence is within the first year and probably within the first 6 months. And so I like patients after withdraw to wait a period of months, 3 to 6, sometimes longer depending on the syndrome, before they restart driving. Some patients driving is so important to them that we just wouldn't consider stopping the drug.
Yeah, I agree that driving is often the driver in these decisions of whether to try coming off or not.
Yeah.
No pun intended that time. And I tend to have them not drive during the taper and for at least 3 months off of medication. And occasionally I'll get another EEG to make sure epileptiform discharges haven't come back. It might be a sign that they're at higher risk.
Certainly in somebody with, I think, generalized epilepsy syndromes, you'd want to do another EEG.
Right. Okay, a couple more questions have come through. The first one is there any relationship between autism and seizures, and is that a risk factor?
I can't quote the numbers chapter and verse, but I think there is a slightly higher rate of seizures in children with autism. I don't know if you know the exact numbers.
Yeah, it's definitely higher.
Yeah.
Depends how the autism was defined and how strictly, but in some of the older studies on autism, is up to 1/3 of them had seizures, so it can be quite significant. Another one is, how do you monitor anti-epileptic drug levels when someone's on an oral contraceptive, or when they go on one or are coming off? Do you need to monitor it, and what kind of timing do you do? Do you just check it once, or?
Yeah, I think that's a very good question. I tend to recheck levels anytime there's been a change. So anti-epileptic drug levels, I use those sometimes to establish a baseline for the patient. So once we've achieved a level of anti-epileptic drug that seems to be controlling seizures and not causing side effects, I get an anti-epileptic drug level. I may check them at other times, but certainly get it there. And that's the right level for them. Sometimes it doesn't fall within the range of what is normal or therapeutic in what the laboratory provides us. But The drug level that prevents seizures and doesn't cause side effects is that right drug level for that person. Establish a baseline, and obviously this is something you want to recheck anytime there's a change, particularly a change that could significantly affect antiepileptic drug levels. For the patient, young woman with lamotrigine, if I have a baseline level, know that that's level for that level for that person, and then they start an oral contraceptive pill, I would certainly check a level afterwards. I'd probably increase their dose of lamotrigine even before waiting for the level,
Right.
but would certainly check and make sure that I've increased enough.
All right, so since the average change, you basically have to double the lamotrigine dose to get about the same level. So yes, I increase it some first and then check a level and then go from there.
Yeah.
And pregnancy, how often do you check them during pregnancy? Is it every month or every?
Yeah, it
2 months
depends
or
on the
so?
drugs. Lamotrigine every month. The most significant changes for most of these drugs, including lamotrigine, are going to be in the second and third trimesters.
Right.
So you're going to want to watch levels even more closely during that time. But it's sometimes just to get into the pattern every month or so works.
Right. It tends to be somewhere around 32 weeks is when they finally plateau and stop needing to go up. But you might need to go up fairly dramatically. And then after delivery, usually somewhere in that first week after delivery, I'll gradually get them right back to their pre-pregnancy dose. Maybe slightly higher since they're going to be sleep deprived and you don't want them having a seizure while they're doing baby care. You do anything different, or is that about the same?
No, and I do warn them that increase in serum level happens very quickly, sometimes within 24, 48 hours.
Right.
And so I do warn women that after delivery, we'll plan to decrease the drug over a period of days. But that they might be dizzy, have double vision, and those could be side effects related to a jump in lamotrigine level.
Okay, well, we've reached our rapid fire round, which the audience may not remember, but we only have a few more minutes, so you only have 30 seconds to answer each of these. Can you make a comment on generic drug? A patient wants to switch to generic because it's costing them too much. What do you tell them?
So I have to do this in 30 seconds. The issue is not that generic drugs are necessarily less effective than the brand name drugs. It is that there are broad ranges for what the FDA defines as bioavailability. Or bioequivalence, and they use two metrics, and basically in either of those metrics, the equivalent drug dose, the equivalent drug level for a dose has to be between 80 and 125% of the brand name drug. So within that range, some people, if you drop the drug level by 20%, might be enough to cause a seizure. In addition, if you switch from a particular type of generic to another particular type of generic, which in our experience happens lots, then the drug level could go anywhere from 125 to 80, which is a 45% drop in serum level, which in many people would be enough to cause a breakthrough seizure. The general practice is if they are on a generic, you would like them to keep on the same generic so that you can ensure that there's not going to be fluctuations in levels. Okay, great. Marijuana and epilepsy. So marijuana and epilepsy is a very popular topic. I'm not sure why, but the effective compound in marijuana that seems to have some early evidence of working is cannabidiol. So the marijuana that's available for recreational use has a number of cannabinoids. The most usually the one present in the highest concentrations is THC, which is the one that produces the hallucinogenic and euphoric effects of marijuana. But that doesn't seem to be the component that is most effective in controlling seizures. Cannabidiol is. There are some ongoing trials looking at purified cannabidiol in liquid form to control seizures. Okay. Couple other questions. One, do you consider gluten a risk factor for epilepsy? So, celiac disease itself, the true autoimmune celiac disease, which is not something I have any particular expertise in diagnosing, can be associated with a number of neurological issues, and I think seizures is on that list of possible neurological issues. The more wider spread intolerance to gluten is not likely a risk factor in most people. I have had the experience of patients saying that they feel better or that they're having few seizures after they eliminate gluten from their diet, and I have to admit some uncertainty about how that works, but it's certainly possible in any individual.
Okay, we'll see if we can squeeze a couple more questions in here. One of them is, do you use levetiracetam or valproic acid for status epilepticus?
Yes. You could speak to this with a lot more authority than I could, but certainly after initial treatment with benzodiazepines, your first-line agents from an anti-epileptic drug perspective could include phenytoin, traditionally phenobarbital, but also intravenous levetiracetam and valproic acid.
Right. I can tell you our official policy now has valproate and phenytoin as equal options as second-line treatment. Not levetiracetam yet, because there's no head-to-head trials showing it's quite as effective. But there's at least 2 head-to-head trials of valproate versus phenytoin, and one valproate was more effective, and the other is equally effective, and in both it was felt to be easier to use and better tolerated. So valproate, yes. We have time for a couple more. Well, there's a question about perampanel. Any particular patients this might be good for, or anything we need to monitor or watch out for with that new drug?
It's a great question. With any of the new drugs, we're sort of still in the phase of collecting what is called post-marketing data, gaining experience with exactly what's going to happen with these drugs. The trials of perampanel used it as an add-on agent in people with refractory seizures, partial onset seizures or focal onset seizures. The main thing that seems to be in our very early collective experience something that's worrisome about perampanel is psychiatric side effects, which in some cases can be quite serious. So I certainly would use that drug with caution in anybody with any psychiatric comorbidities.
Thank you for covering for me while I was getting a question in my ear. Patients with migraine and seizures, any particular advice?
Yeah, I think, obviously the primary goal is going to be control seizures, but you might want to choose a drug that has some efficacy against migraine. The list of those can include topiramate, valproic acid, gabapentin, and pregabalin.
And zonisamide, do you think that's good anti?
I don't have a lot of experience with that. I don't know. Are you aware of any trials?
I know our headache colleagues use it sometimes as well. So. Okay. And how about obesity? Our overweight patients with epilepsy. Yeah, so particular recommendations?
There may be some drugs you want to avoid, especially at higher doses. Valproic acid would be one. In my experience, pregabalin can result in significant increases in weight, and I think gabapentin to a lesser extent. Topiramate and zonisamide, as well as felbamate in refractory epilepsy, can have the opposite effect, appetite suppression and significant weight loss.
Right. Topiramate and zonisamide are the main ones for that.